So hello everyone and welcome to our webinar on endo-hepatology, the role of endoscopic ultrasound in liver disease. We're so glad that everyone's able to join us this evening. This event is co-hosted by Olympus and Women in Endoscopy. Olympus is a proud partner and supporter of WIE in their mission to promote and create more opportunities for women in the field of endoscopy. Tonight we will hear from our educators, Dr. Shivangi Kothari and Dr. Allison Schulman. To our audience, we would ask that you please mute your lines and feel free to ask questions at any time using the chat feature on the side of your screen. This is an industry-sponsored event, therefore we are not able to discuss off-label use of products. If you have an off-label question, we would ask that you please save it for after the event. If you are unaware if a question is off-label, we will kindly ask the presenters to move on to the next question. At Olympus, we have to read our disclaimer slides prior to our webinar. This presentation is for your general knowledge and background only. EUS is to be performed according to the standard technique and is left to the operator's experience and skills. Olympus makes no representation, warranties, or other expressed or implied warranties or guarantees regarding the accuracy, reliability, or completeness of the information. Proper attribution should be provided for any use of the information contained in this presentation. Under no circumstances shall Olympus or its employees, consultants, agents, or representatives be liable for any costs, whether direct, indirect, special, incidental, consequential, or otherwise, that may arise or be incurred in connection with the information provided or any use thereof. Dr. Shivangi Kothari and Dr. Allison Schulman, the authoring physicians of this presentation, are paid consultants to Olympus Corporation of the Americas. The comparison to competition has been written to the best of our knowledge at the date of publication. Please keep in mind that our competitors enhance their products as well, so their products may have changed. Make sure you use competitor comparisons carefully in your conversations. This material does not constitute medical or legal advice and should not be relied upon as such. This material should not be considered as a substitute for carefully reading all the applicable labeling, including the instructions for use, IFU, supplied with the devices, and published peer-reviewed articles concerning the topics presented. Therefore, before using or selling any product, please thoroughly read the relevant user manuals for instructions, warnings, and cautions. The techniques, instruments, and settings can vary from facility to facility, and it is the clinician's decision and responsibility to decide in each clinical situation which mode and setting they use. Tonight, there are two learning objectives for the webinar. The first of those is to better understand the role of EUS in the diagnosis and management of liver disease, and the second is to learn how to work with the hepatology and radiology departments to add EUS-guided evaluation to your practice. I would like to take a moment to further introduce our educators. Dr. Shivangi Kothari is an Associate Professor of Medicine and the Associate Director of Endoscopy at the University of Rochester Medical Center. Dr. Kothari completed her gastroenterology and hepatology fellowships at Seton Hall University School of Graduate Education, Medical Education, and her advanced endoscopy fellowship training at Stanford School of Medicine. She is a member of a variety of national and international committees, including the University of Rochester's Women's Mentoring and Career Development Committee and Women in Endoscopy. Dr. Kothari also serves as the chair of the ACG Women in Gastroenterology Committee. I would also like to introduce Dr. Allison Schulman. Dr. Schulman is an assistant professor of internal medicine in the Division of Gastroenterology and Hepatology, an assistant professor of surgery in the Department of General Surgery, and director of bariatric endoscopy at the University of Michigan Hospital. She completed her gastroenterology, bariatric endoscopy, and advanced endoscopy fellowships at Brigham and Women's Hospital. Dr. Schulman's research is focused on endoscopic management of obesity and complications of bariatric surgery, as well as interventional hepatology. Dr. Schulman is a member of the ASGE, ACG, AGA, SAGES, Women in Endoscopy, and ABE, among others, and serves on several society committees and advisory boards. I will now turn it over to Dr. Kothari to speak about the role of EUS in the diagnosis and management of liver disease.
I would like to thank WIE and Olympus for giving me the opportunity to speak on a very important topic and evolving as well, to talk about the role of EUS in liver diseases. I will primarily be focusing on EUS in liver biopsy, and Dr. Schulman will then talk about all things that EUS has in addition to liver biopsy in the various liver diseases and conditions. So starting off, with the abnormal liver enzyme workup, we primarily first start off with the basic blood work, a detailed HNP, autoimmune workup, medications, alcohol use, evaluate for any kind of imaging that the patient may need with ultrasound, MRI. Of course, if a biliary cause is found, then ERCP is performed as indicated. If liver biopsy is needed for further evaluation or diagnosis or staging of any of those conditions, then a percutaneous liver biopsy or a transjugular liver biopsy have been the traditional modalities used. Transjugular is usually performed in the presence of large ascites, coagulopathy, or if the patient also needs portal pressure evaluation. And these have been the traditional approaches for obtaining a liver biopsy. So where does EUS-guided liver biopsy fit in in this patient evaluations? And coming to which patient is suitable for a liver biopsy, it primarily start with any patient who needs a liver biopsy and also needs an EGD for any reason, for whether Barrett's screening or surveillance, variceal screening, abdominal pain, any indications for an EGD. Or if the patient also needs an EUS for evaluation of the pancreas, common bile duct, gallbladder, or FNA for any etiology. If the patient is very anxious for a percutaneous biopsy, cannot cooperate in breath holding, patient requires sedation, then those patients can undergo EUS-guided liver biopsy. Or if patients need biopsy of both the right and left liver lobes in cases of non-alcoholic fatty liver disease or any kind of regional or patchy disease involvement of the liver. So who's not a candidate for an EUS-guided liver biopsy? Anybody with thrombocytopenia, platelets less than 50, coagulopathy with an INR greater than 1.5, or patients with significant ascites. So with any new modality or anything that's changing the paradigm from what has been established at a traditional approach, you always want to know whether it is safe, whether it is clinically effective when compared to traditional approaches, and what is the benefit of doing an EUS-guided liver biopsy. And I will go over the literature that's out there in assessing if the literature supports our questions and we're able to get the answers that I just posed. So a multi-center study of over 110 patients using a 19-gauge FNA needle revealed that EUS-guided liver biopsy produced specimen adequacy for pathologic diagnosis in 98% of the cases, with a mean tissue length of 38 millimeters and a median complete portal triad of 14. There was just one complication that was a self-limited bleeding in a coagulopathic patient, and it was managed conservatively. So does EUS liver biopsy compare to the traditional approaches when, compared with the percutaneous or the transjugular biopsies? And in a study comparing a 19-gauge needle to an 18 or 19-gauge needle used for a transjugular approach and an 18 or 20-gauge needle used for a percutaneous approach, EUS-guided liver biopsy of both the liver lobes produced significantly more tissue compared to the percutaneous approach. EUS-guided liver biopsy also produced significantly longer total tissue specimen lengths compared to the transjugular approach, and also produced similar complete portal triads. In patients that just had one lobe sampling, there was no difference in the tissue that was obtained with the three modalities, suggesting that EUS-guided liver biopsy performed either equally or superior if both the lobes were sampled compared to the traditional approach of percutaneous or transjugular biopsies. Our institution also has presented our data comparing EUS-guided liver biopsy using an FNA or an FNB needle, comparing it to transjugular and percutaneous approaches. And EUS-guided liver biopsy provided adequate tissue and histologic diagnosis when compared to both the transjugular and percutaneous approaches. So which needle to use now? There have been multiple studies looking at 19 gauge, 22 gauge, comparing the 19 gauge FNA versus 19 gauge FNB needle. A prospective randomized trial looked at 40 patients comparing the 19 gauge FNA versus a 19 gauge FNB needle. And what they found was FNB performed better than FNA in terms of aggregate specimen length, the length of the longest piece obtained with the biopsy, and the total specimen complete portal triads. There was no difference in the adverse events in the two groups. So, we pick a needle. Now, which method to use for the biopsy? And, there have been studies looking at dry suction versus wet suction. And a study of 120 biopsies reported specimen adequacy in 98% of the wet suction group. And the length of the longest piece was significantly greater for wet versus the dry technique. The aggregate specimen length was significantly higher for the wet suction at 49.2 millimeters versus 23.9 millimeters for the dry suction. The mean complete portal triad was higher for the wet suction versus the dry suction method. And there were more median and large fragments obtained with the wet suction. So we decided on the suction modality. Now, how many actuations once you've poked the lobe, and a prospective randomized trial compared one pass with just one actuation or one pass with three actuation needle movements to see which one performed better. So in 42 patients randomized to either 1:1 technique or 1:3 technique. The 1:3 technique performed better than the 1:1 technique with producing significantly longer aggregate specimen lengths and more complete portal triads. So sampling one lobe versus both lobes, that's the other controversy. As I said earlier, there could be patchy involvement of the disease entities in the liver, and in 38 non-alcoholic fatty liver disease patients, comparing one lobe versus a bilobar evaluation, sampling of only the right lobe underestimated fibrosis in 21%, inflammation in 13%, and steatosis and ballooning in 8% of the cases. And this is mainly due to the regional variation of the disease, and thus the bilobar liver biopsy did improve assessment of disease activity as well as fibrosis in these patients. So coming to the overall performance and safety of EUS-guided liver biopsy, a recent meta-analysis, we can go to the next slide, of 9 studies and over 400 patients reported a pooled rate of successful histologic diagnosis in about 94% of the patients. And the adverse event rate was about 2.3%, and this was lower in the FNA needle, and the overall diagnostic yield was about 95% in the 19 gauge FNA needle group. So the question is, are we able to safely obtain histologically adequate samples for liver biopsy with EUS? And the answer is yes. Coming to the answers of the 3 questions that we posed initially with EUS-guided liver biopsy. First question is it safe? And the answer is yes. The adverse event rates are comparable to the traditional approaches. And that's mainly because it's performed under real-time imaging. We can avoid significant blood vessels using the Doppler while performing endoscopic ultrasound. And overall adverse events are low. is it clinically effective compared to the traditional approaches? And we did see that it does produce equal or superior samples compared to the percutaneous or transjugular biopsies. And bilobar sampling, of course, helps reduce the sampling error. So what are the benefits of EUS-guided liver biopsy? Because we can perform it along with an EGD in patients that do require both the procedures, such as, Barrett screening, abdominal pain, or evaluation of the pancreas or gallbladder that's required in addition to the liver biopsy. It is cost effective if the patient requires both the procedures. Again, in patients that are very anxious or require sedation, you could perform the EUS-guided liver biopsy. And in patients that are obese and that cannot get a percutaneous biopsy, you can perform an EUS-guided liver biopsy. So how do you build an EUS liver biopsy program at your institution? And it is a multidisciplinary approach. It is in collaboration and working closely with your hepatology and IR colleagues. You need a good pathology collaboration. Somebody who's an expert in reading these and is well versed with handling the samples that we sent them. Careful patient selection is key. As I said earlier, if the patient needs an EGD or any EUS evaluations, those would be really good for doing an EUS-guided liver biopsy. The key is you want to avoid complications with any kind of a new program or any new intervention that you're introducing at your institution. If your first 5 procedures have complications, it's not gonna be a good thing for the program. So make sure you carefully select your patients, work closely with your colleagues, and a multidisciplinary team is always key to any new program.
Thank you, Dr. Kothari. I think we have a few questions here. And so the first of those is you spoke a lot about using 19 gauge needles for EUS-guided liver biopsy. Is there a circumstance where you might select a 22 gauge or a 25 gauge for biopsy? And have those needles been as effective as 19 gauge needles like you discussed?
Right. So there are studies that have compared 19 versus a 22 gauge needle. And the main thing is, the smaller the needle, the smaller the specimen you're going to get. So the smaller the thickness of the specimen, it is more prone to fragmentation and becomes harder for the pathologist to get an adequate evaluation. I would not use a 25 gauge for getting a liver biopsy. I have used a 25 if I'm FNAing a metastatic lesion or something in the liver. But to get a liver biopsy for assessment of histology, the literature has suggested a 19 gauge FNA or FNB needle are the way to go.
Thank you. And I think we have one more question here, and it's how do you work with IR and hepatology, and how do you get these cases referred to you from your interventional radiology department or your hepatology department?
So the way I started it, the same things that I'm discussing here, I discussed it with my hepatology colleagues, and they, again, carefully selected the patients. And the keys, once they start sending you one patient, the second patient, and they see that, it is effective and you're able to get answers, it becomes easier for them to tell the patient that, yes, you're going to need this endoscopy or something, and they can do your liver biopsy at the same time. And that will save you another procedure. And with the IR colleagues, again, we always have, as interventionalists, a good working relationship with our IR colleagues. So there are times where, patient is not a good candidate for a percutaneous approach. And if patient is going to need sedation, is going to need an endoscopic intervention, then our IR colleagues are very okay with referring them to us. So it is mainly about building relationships and knowing that there will be patients that we cannot do the EUS-guided liver biopsy, that will be managed by IR. So it is a collaboration. You're not here to take over anybody's territory, but everybody working in sync.
Wonderful. Thank you. And we did have one more just come through here. You did reference heparinized suction techniques in one of your pages, literature pages, a few slides back. And so participant has a question is, do you use heparin in the needle when you're doing EUS-guided biopsy?
Yes. So I flush the needle with heparin and then use 2 cc's of wet suction with sterile water or saline in the suction needle in the syringe when I do it.
Great, thank you. So we will move on to your final slide here.
So in conclusion, EUS-guided liver biopsy is becoming more commonly used and it can be cost saving when the patient needs an EGD or EUS at the same time. It allows for bilobar sampling, and EUS-guided liver biopsy has been shown to be safe, provides adequate tissue compared to the traditional approaches. And as I said, careful patient selection is key, and collaboration with your hepatology and IR colleagues is very essential.
Thank you, Dr. Kothari. We are going to hand it over to Dr. Allison Schulman.
So thank you very much for the invitation to speak today. It's such an honor to be here. Thank you to Women in Endoscopy and also Olympus. It's great to be lecturing alongside Dr. Kothari. I was similarly asked sort of why we evaluate the liver with EUS. And while Dr. Kothari focused mostly on liver biopsy, I thought I would give a rundown of sort of where the field of endohepatology is and where it's potentially going in the near future. So as many of us are familiar, EUS has really evolved from a diagnostic to a therapeutic procedure. And this has very much revolutionized endohepatology. And as a result of this, there's really been an impressive paradigm shift toward endoscopic management of diseases that have traditionally required percutaneous or surgical approaches. And in this field, new techniques and devices have evolved for both diagnostic and therapeutic capabilities. And so this has really been a launching point and very exciting for the potential expansion that we'll see in this field in the coming years. And so I just wanted to quickly show you through these illustrations how easily accessible the liver parenchyma, the gallbladder, the biliary system, the hepatic vasculature is through both the gastric wall and also the duodenal wall. And we'll get back to these figures a bit later when we touch on sort of how the field of endohepatology has opened opportunity and how it continues to evolve to create new minimally invasive options for patients who do not want to undergo percutaneous or surgical interventions. And while the field of the devices and the interventions have evolved, the landscape of liver disease is also evolving. And so there's really an alarming increasing incidence of non-alcoholic fatty liver disease, NAFLD, and also non-alcoholic steatohepatitis, known as NASH. And distinguishing these two entities is critical. You must really assess disease severity and also severity of fibrosis. As the treatment, while typically weight loss is the treatment for both of these, there's also costly therapeutic agents that oftentimes rely on sampling to be approved. And so there's this clear increased need for thorough evaluation and sampling, like we heard through Dr. Kothari's talk. And this change in landscape is clearly reflected in this slide, which demonstrates changes in indication for liver transplantation over the last few decades and projections through 2025. And you can see that the major driving etiology at this point is NASH. And so we really have to have better and more accessible modalities for distinguishing this entity from NAFLD, diagnosing it earlier, and also treating it earlier. So I thought I would just spend a few minutes sort of discussing some of the new and exciting or evolving techniques in endoscopic hepatobiliary diagnostics, and then moving on to discuss the endoscopic hepatobiliary therapeutics. So we're going to start just very briefly with liver biopsy, but then we will quickly move on to the other topics that have not yet been covered. So as we heard from Dr. Kothari, this has been a really exciting part of endoscopic ultrasound over the last several years. And these are really increasingly being performed with coring needles, like fine needle biopsy needles. As we eloquently discussed, this is very technically simple. There's no percutaneous puncture. It's not painful. And it's also image guided. And so it allows the avoidance of blood vessels, very small blood vessels. And as we heard, all the data that surround the safety and feasibility and specimen adequacy and sort of technique that has really driven this field. So another exciting component of the field is elastography. And we know that FibroScan, transabdominal FibroScan, has really decreased the clinical need for liver biopsy in many patients. But there's a whole variety of shortcomings that exist. So patients with ascites or with very thick abdominal walls or subcutaneous tissue, or in patients with hepatic atrophy, oftentimes those values do not actually reflect the true level of fibrosis. And FibroScan also has a difficult time distinguishing F2 from F3 disease. Real-time elastography, which is of course performed via endoscopic ultrasound, measures tissue stiffness and also compressibility of the tissue. And there's been several reports that it can help in distinguishing this F2, F3 distinction. And this is becoming increasingly used in the endoscopy suite. So some of the research that we originally performed, as you can see here, it's very easy to access, as we had discussed through the liver biopsy talk, both the left lobe and the right lobe of the liver through endoscopic ultrasound. And you can do so through the gastric wall and then also through the duodenal wall. And what we showed in a manuscript that we published several years ago is that the values that we see by EUS-guided elastography seem to correlate with abdominal imaging. And so this offers the new potential of being able to sort of understand various aspects of someone's imaging, not just looking at a single component of the liver. EUS-guided portal pressure is also something that's sort of new and exciting in this field. And so while traditionally HVPG, or hepatic venous pressure gradient, has served as a proxy for portal pressure measurements, now we have the capability of directly measuring the pressure in the portal vasculature. And so this is important because when we think about patients with cirrhosis and F4 disease, clearly there's a distinction in those who develop decompensation versus those who remain compensated. And that really predicts who's going to develop varices and who will have other complications of their liver disease. And so the pictures in the bottom sort of show how the portal vein looks under endoscopic ultrasound, a 19-gauge needle through which you can thread a portal pressure measurement, and also what it looks like on fluoroscopy. And now, of course, there's a commercially available system for this. So moving on to endoscopic hepatobiliary therapeutics, we'll start just briefly discussing endoscopic ultrasound-guided biliary drainage and gallbladder drainage. And really become part of our day-to-day repertoire and allows us to intervene in ways in which patients previously would have had to undergo either percutaneous or surgical drainage. And so you can see there's a whole slew of different devices and techniques that are available for accessing the biliary system or the gallbladder in patients who may not be able to undergo sort of conventional access. And that includes choledochoduodenostomies, direct gallbladder drainage as opposed to cystic duct stent placement, and then also accessing the left hepatic ducts in patients, doing a hepaticogastrostomy in patients who may have obstruction that precludes conventional ERCP. And then another sort of exciting aspect of this field is the idea of performing EUS-guided hemostasis. And so when we think about the management of bleeding gastric varices, traditionally this has been performed by interventional radiology, but there's a whole slew of different endoscopic techniques that are also evolving and very exciting in this field. And so many of those are direct, like band ligation or direct injection of a thrombogenic agent. But as we get to my case, we'll be talking a little bit more about EUS-guided coiling and injection of thrombogenic agents, which is a new sort of exciting way to manage these complications of liver disease. And one sort of newer, exciting component of this field that is still sort of in the research phases, but exciting to think about how sort of device development may ultimately change the whole way that we think about placement of a transjugular intrahepatic portosystemic shunt, which many of us are familiar with and known as TIPS. And so, of course, we know that this involves the creation of low resistance channels between the portal vein and the hepatic vein. And deployment of these stents allows blood to return to the systemic circulation. And we know that these are typically performed by interventional radiology, but this is sort of a new and exciting front that we may take over at some point, depending on device development, as interventional endoscopists. And so just to bring us back to these original pictures, as we were discussing before, you could almost create a one-stop shop for a patient with liver disease. So you could band gastric varices, you could sample liver tissue while you're down there and banding or screening for varices. You could also get liver elastography of both the left and the right lobe to understand what degree of fibrosis the patient has. And then simultaneously, you could measure the portal pressure gradient and get a sense of whether or not that patient may be predisposed to decompensation. And then, of course, we can intervene therapeutically as well. So we can also treat gastric varices in patients with known liver disease and known bleeding. And then we can also bile duct drainage, gallbladder drainage. We can even offer tumor ablation in patients with hepatic tumors. And so this is a really exciting field, and I think the best is yet to come. But endo-hepatology is sort of really just taking off with the development of all these new devices and techniques.
Thank you very much, Dr. Schulman. I am not currently seeing any questions in the chat at this time, so I think that we can transition over to our case review. I would just encourage our participants to use the Q&A or chat function to submit your questions throughout the duration of the case review, as we will have a Q&A section after the case reviews where we can discuss further any questions that our attendees might have. So thank you again, Dr. Schulman. We are going to kick off case review with Dr. Kothari and her first case.
Thank you, Dr. Schulman, for an amazing review, and that brings to my case. It's a 77-year-old male, history of diabetes, hypertension, chronic kidney disease, hyperlipidemia, atrial fibrillation, also has history of Barrett's esophagus, was seen in the GI clinic, had to schedule his surveillance EGD. Last one was 3 years ago, and was found to have newly elevated liver enzymes at the lab work done by his primary care provider. Did not report any other symptoms. Labs revealed an ALT of 250, AST of 300, ALK-Phos of 300, and a total Billy of 1.5. Right upper quadrant ultrasound was performed, which revealed a hyperechoic liver consistent with fatty infiltration. There was no mass lesion reported or gallstones, and the CBD was reported to be normal. He did undergo chronic hepatitis and autoimmune workup, which was negative. So the plan was made for the patient to get the EGD for his Barrett surveillance and also perform EUS-guided liver biopsy to further investigate his elevated abnormal transaminases, and also stage his fatty liver, or whether it was just NASH or steatosis. So at endoscopy, as you can see, he had Barrett's, and surveillance biopsies were performed. And EUS, you can see here, EUS-guided liver biopsy was performed with 3 actuations in both the lobes. And that's the specimen retrieved. And at pathology, the pathologist had adequate tissue. They reported a cirrhotic nodular architecture. There was moderate micro and macrovesicular steatosis. Trichrome stain showed cirrhosis with dense lymphocytic infiltrate within the fibrous bands. Reticulin stain showed normal thickness of the trabeculae. There was no evidence of hepatocellular dysplasia or neoplasia. There was no evidence of alpha-1 antitrypsin disease by PAS staining. Iron stain did not show any significant iron deposits. Immunohistochemical stains, and the pathologist did have enough tissue to do all the immunohistochemistry. And the stains showed that the atypical lymphoid infiltrate were positive for CD5, CD20, and CD23, and negative for cyclin D1 and CD10. And the patient was diagnosed with a low-grade B-cell lymphoma. And these are the pathology slides with the different stains showing the positive CD5, CD20, and CD23 stains. The patient underwent staging CTs, which revealed several subcarinal, mediastinal, and enlarged abdominal lymph nodes. He was referred to oncology and was started on chemotherapy. And at follow-up labs and CT, there was resolution of his mediastinal lymph nodes as well as resolution of his liver enzymes. And this just highlights the role that EUS-guided liver biopsy played in the evaluation of this patient and performed at the same time as his Barrett surveillance endoscopy.
So thank you very much, Dr. Kothari. I am not seeing any questions at this time, so we will move on to case 2 with Dr. Schulman.
Perfect, thank you. So this was a 73-year-old male with decompensated NASH cirrhosis, which was complicated by ascites, hepatic encephalopathy, and esophageal varices. And he'd come in several times with esophageal variceal bleeding. He was banded 2 times during acute bleeding cases and then 2 other times as an outpatient. And then about 6 weeks after his last banding, he presented to the emergency room with hematemesis. And the inpatient on-call team did an upper endoscopy, which demonstrated a massive clot in the fundus and the development of large gastric varices. And so interventional radiology was notified. The patient underwent TIPS placement, also eventually underwent BATO and also BRTO with resolution of the bleeding. And he was eventually discharged home, and he did well for weeks, but then re-presented. And when he came in the next time, he had massive hematemesis and this time melena as well. He was hypotensive in the emergency room, and his crit had noted to go from 35 to 23. He was sent to the intensive care unit. He was started on fluids and also pressors. And interventional radiology was notified, and he underwent a TIPS check, and this demonstrated a normal gradient. And so this case really demonstrated the importance of working with your team and the importance of multidisciplinary management when it comes to liver disease. And so we had a multidisciplinary conference to discuss what were the next steps. It was deemed by our interventional radiologists that there were no other alternatives from their standpoint. And so we discussed the possibility of doing an EUS-guided approach. And just as a quick reminder, gastric varices are present in over 20% of patients with cirrhosis, but probably the more important part of this is that they oftentimes present with more severe bleeding than esophageal varices. And the traditional treatment up until maybe the last year or so has been IR-based entities such as TIPS, although endoscopically we oftentimes are also injecting thrombogenic agents. However, EUS-guided coil embolization has really emerged, especially over the last several years, as a promising modality in this space. And so I just want to show you this patient's video. As you can see here, there's large gastric varices, one of which has a white nipple sign. On endoscopic ultrasound, you see these massive varices that are just adjacent to the gastric wall. And here you can see me passing a 19-gauge needle deep within the varix. You really want to start sort of distally in the distal end of the varix and then release these coils until the varix is entirely obliterated. And so you can end up putting in several meters of coil before you've completely obliterated a varix that's this large. And then after complete obliteration, you can see here that I'm mixing a substance, which is sort of like a glue, and then injecting it around all the coils. And then at that point, you can see, I think the video just stopped, but under endoscopic ultrasound, you can see complete obliteration of the varix, which is what you want to see. And I also do these procedures under fluoroscopy, so you can see the coils being deployed through your 19-gauge needle to confirm appropriate placement. And so this patient did great. He had no recurrent GI bleeding, his labs all improved, and he was actually discharged home the following day. He had a repeat upper endoscopy 6 weeks later. It demonstrated nearly complete resolution or obliteration of the gastric varix that we had treated. And at this point, he's about 5 months out without any complaints, doing great at home. So in conclusion, endoscopic ultrasound has clearly evolved from a diagnostic to a therapeutic procedure. The field of endohepatology is really exciting and probably really just at its launching point in terms of sort of its rapid emergence and the use of new devices into this realm. It offers oftentimes a more efficient and less invasive option for making the diagnosis and for managing the diagnosis, especially in light of this changing landscape. And so I think with further device development and sort of refinement of these techniques, there's really the potential for exciting expansion.
Wonderful. Thank you so much, Dr. Schulman. We appreciate it, and to Dr. Kothari as well. So we are going to move on to the Q&A portion of the chat. So I'm just going to open up our chat boxes here. And we do have a few questions coming in, so I apologize while I open these up. And the first is a great one, and we'll pose this to both of our educators tonight, and you both have the opportunity to answer. And what is your advice, or what advice do you have for those fellows or junior faculty who are interested in getting trained in endohepatology? So Dr. Schulman, I'll hand it off to you first.
Oh, okay.
Sorry.
Perfect. I was going to say I'll defer to Dr. So that's a great question. And I think that questions like this hold true for really any unique niche within our field. There's a lot of things that are evolving. There's a lot of new and exciting techniques that you can offer and that you can learn, but you want to make sure that you are well trained from a cognitive standpoint and from a technical standpoint. And so I think as fellows and junior faculty, the best way to get this exposure is by locating people or interventionalists around the country. And of course, this is a weird time in light of COVID, but who are doing the procedures that you're interested in doing. Because I think there's no replacement for shadowing and trying to get some hands-on exposure. The second level of training, and maybe perhaps might be the first launching point to then finding those faculty, are to partner with industry and also your societies. So I know the ASGE has a variety of courses that they offer that teach you some of the basic techniques. There's, of course, from an industry standpoint, a whole slew of different mechanisms for learning these types of cases. You can discuss locally with your reps. You can go to courses that industry offers. But I think that there's invaluable experience with actually identifying mentors who are doing the types of cases that you want to do and trying to train with them.
Great. Thank you, Dr. Schulman. And Dr. Kothari?
Yes, I will echo what Dr. Schulman just said. The key is to be well versed as to, starting the program. Make sure you collaborate. First find the need for at your institution, collaborate with your hepatologist, and then find experts where you can get guidance, get some hands-on experience through courses. attending various, and again, the ASGE, ACG, the industry, everybody has trainings going on. Again, this is, pre-COVID, but hopefully soon. And again, platforms like this webinar where you can understand the cognitive aspects that go into these programs are very essential. And then you take the training back and always have a partner or a senior faculty or someone you want to start off the program with, especially if you're junior and just starting out, so that way you have backup. Make sure you have enough backup when you're starting off these.
Thank you both. And so along those same lines, one of the questions we have here is, we described a lot of different types of procedures, the first of those really being liver biopsy, but a lot of other highly technical procedures were described by Dr. Schulman. And so I would just ask you both again, pose the question to both of you, what the learning curve is associated with EUS-guided liver biopsy, but also some of these other more technical procedures. I know you've just touched on it a little bit here, but if you could speak a little bit more about that. So Dr. Kothari, I'll let you go first.
Yeah, so I think it applies the basic principles of EUS and FNA first. And I tell all my fellows this is, you always want to have a strong foundation of endoscopy on which interventional endoscopy like EUS ERCP and then interventional EUS builds upon. So the key is to have strong foundation for EUS and FNA that helps build onto the liver biopsy platform. The knowledge of the needles, the selection of the right patients, identifying the ascites or whatever you can on the EUS is important. And and key is that you put those techniques into use. And then for the other ones, EUS liver biopsy, I would say is technically not that challenging. However, if you're doing EUS-guided coils or EUS-guided gallbladder drainage or bile duct drainage, you need to make sure you have a good IR backup. If, of course, things go south, you have the adequate tools, the needles, the wires required, the coils that's needed. So the key is to have all your I's dotted and T's crossed.
Thank you, Dr. Kothari. Dr. Schulman?
So I totally echo and agree with everything Dr. Kothari said. It's really important, I think, to have, in many ways, just to have the basics of endoscopic ultrasound down or interventional endoscopic ultrasound down before you approach a new and exciting field like endo-hepatology. I would say, once you've been able to get EUS-guided biopsies or fine needle aspirates of a variety of different pancreatic lesions or gastric lesions, EUS-guided liver biopsy is not that different, just like Dr. Kothari said. It's just I'd say the one thing that may be a little bit different is the possibility of running into bleeding or some complication, and not that it is common, and usually it's very avoidable because you're looking at it under direct Doppler, but just that it's an evolving and slightly newer field that is sort of, you're working in conjunction with your interventional radiologist. And as Dr. Kothari mentioned in her talk, it's ideal not to have a major complication when you're introducing a new technology into your practice. And so the field itself, or the actual procedure itself, is very similar to anything else you may do, because you sort of have your choice of liver parenchyma. You can decide where you want to go. You're not looking for a discrete lesion. You're just looking for a safe place to access, whether it be the left and the right lobe. And so the actual technique is quite straightforward and simple once you've had exposure to endoscopic ultrasound in general. In terms of doing procedures like the EUS-guided coiling that I showed you, again, I think it takes just a level of comfort with the endoscopic ultrasound device, and then maybe a good mentor or someone to talk you through the details of how you would perform it safely. There's a lot of little minutia that become important when you do something like that, which includes sort of where is your access point through the GI tract to reach the gastric pharynx. You would think that you'd want to be sort of in a retroflexed position up into the gastric fundus, directly looking at it, but that's actually it's somewhat counterintuitive. But actually, a better position is through the distal esophagus, because your scope is straight. You have better control of your instruments. You don't have a weird torque in the scope that's not going to allow the EUS needle to easily pass into the varix. And then the second step is sort of once you are in good position and you see the vessel, then you want to obviously access the vessel with your needle. And at that point, you just want to think about sort of who is in the room, who's going to be leading the advancement of the coils. You know, for the interventionalist, it's actually not as much work. You're sort of advancing the needle in, but you have to make sure that your tech or your nurse or your fellow, whoever is exchanging and reloading the coils, is ready to go and understands the technicalities of those, because there's a couple things that are a little bit unique depending on which type of coil you select and whether or not you're using a 19 gauge or a 22 gauge needle, and what size coils will fit through each of those. And so to make it seamless, it's very helpful to sort of speak with a mentor or someone who has done a lot of these and to let them talk you through the steps of doing it safely. That's certainly how I did my first case, independently, I should say. When I trained, I did some of these, but when I did my first case independently, I really spoke at length with one of my mentors who has done a lot of work in this field. And then the next step is sort of once you know where that your coils can be loaded in safely, where do you start and how do you know when you're done? And so all of that, it's just helpful to think about like the feel of it, because you want to put in as much coil as you possibly can, but once you feel your needle sort of pushing you back, do you want to continue to place coils and leave one sort of in the gastric wall, or do you want them all to be within the varix itself? And so there's a lot of technicalities that you may not really fully flush out with other procedures in endoscopic ultrasound like you would with maybe liver biopsy. And so it's just important to, like anything in interventional GI, to do things safely and effectively. You want to make sure that you're well versed in sort of the steps and what could go wrong. So that's probably all I would say with that.
Thank you, Dr. Schulman. And so just a point on safety and efficacy as a note, Olympus needles and guide wires are not on label for this application. So just to clarify for our audience, but we do have some other questions that came up from your discussion points. You mentioned the potential for adverse events during EUS-guided liver biopsy. The question is, how do you handle an adverse event like a bleed? Because we know that there are several techniques. I believe that it's a physician at UC Irvine does a zigzagging technique if he potentially identifies that he has hit a particular vessel as he's kind of withdrawing the needle. Do you have any techniques for addressing adverse events like a bleed during EUS-guided liver biopsy? And I'll hand it to you, Dr. Kothari.
Yeah, so the key is, I do it straight from the right lobe and the left lobe. I use the Doppler very freely initially after I've picked the path I want to take. And the key is you want to avoid the big blood vessels, and we do watch out for the patient in recovery, and the vitals are being monitored. The key is knock on wood, I've not yet had a life-threatening bleed, and we've that's and again, all the big studies have shown less than 1% significant bleed, and that was also in a coagulopathic patient. So key is you want to watch these. Of course, if who suspect a bleed, monitor the patients. A lot of time, these are self-limited, and this is where your relationship with your IR colleagues will come into help, because at that point you could call your IR friend and say, hey, buddy, I may need backup, or watch the patient. The key is always, if you suspect that I always watch the track. After I've done the biopsy, I watch the track for any bleeding after I've biopsied it. So that's always key. And if you feel like there could be some bleeding, watch the patient longer. You may want to keep the patient for observation. And again, if the patient has a significant bleed, then of course have IR weigh in.
Great. And Dr. Schulman?
Yeah, I totally echo everything that was said. And sometimes I similarly, I need wood to knock on before I say this, but I similarly have not run into this. They usually are self-limited. And, the ones that have been reported occasionally, they require transfusions. And I agree, if you're worried, and sometimes you can see either bleeding in the tract or bleeding in the syringe, then keep the patient longer, maybe turn the patient to their right side so that the pressure, can sort of tamponade the area in the liver that may be affected. But these are very safe procedures because of the fact that, unlike the percutaneous approach, we have the ability to watch our needle under Doppler. So it's really just about making sure that you take your time during the procedure and that you're avoiding areas that are concerning to you.
Great. Thank you so much. And we have another great question here. And I'll pose this to both, and I'll start with Dr. Schulman here. What percentage of the cases in your practice are liver cases, and are they growing?
That's a very good question. I feel like bariatrics is flooding my practice recently, certainly in clinic and also in endoscopy. But we do see, with the overlap of bariatrics and liver disease, we definitely are seeing an increased number of cases that we're performing in sort of the endo-hepatology realm. I think a lot of this is also that our group over the last several years has really built up nice relationships with our surgeons, with our interventional radiologists. And so we're getting referred more and more cases, and it's not a competitive thing. It's sort of a multidisciplinary way that we approach all of these patients and their care. And so I've actually had recently some of the IR attendings reach out to me to say, hey, we should discuss protocols for EUS-guided coiling. And there's certain cases where we think that might even, that might work better or equal to what we're doing. And if we're busy, it might be very helpful to have you available. And then they will actually come to the endoscopy suite to watch the cases and to give their input. And so we are definitely seeing a rise in these cases. I think part of it is that we're sort of seeking them out as well because it's a new and exciting field. And I think at this point, it's only limited really by device development and by how we can sort of best intervene in a minimally invasive way. And so we're getting more and more referrals. We're excited about it. We're working very closely with our multidisciplinary teams for the safety of all of the patients. But I also think that it's sort of a new and exciting topic and focus for industry to sort of provide us with the tools to do more and more in this realm. And we're starting to see a lot of that with biliary access and gallbladder access and everything else. So it'll be fun to see where our field goes in the next, 5 to 10 years.
Thank you, Dr. Schulman. Dr. Kothari?
Yeah, I totally agree with Dr. Schulman. It's hard to put a percentage because we have a very complex overlapping endoscopy practices between all things therapeutics. But yes, the field is certainly evolving. The number of cases are increasing, and that's a combination of all things EUS-guided biliary access or liver biopsy or coil or gastric varix management. But yes, it is getting the cases are rising for sure. And again, it's like with any other program, you do a good job and then floodgates open up and then IR calls Dr. Schulman, come down. So that's good. The truth with any new program is, and that's why I said earlier, avoid the complications because it does not bode well for a new program that you're starting off.
Great. Thank you both so much. And we have one final question here before we start to wrap things up. And that is, do all patients who are diagnosed with fatty liver disease recommended to have a biopsy, or are there cases that are managed with just imaging? So Dr. Kothari, if you could kick that off.
So that's a discussion I have with my hepatologist. So the answer is no. Not every fatty liver needs a biopsy, and we have non-invasive methods that are available. So the key is the discussion between your hepatology colleagues, looking at the patient's BMI. Again, as I said earlier, if the patient needs an endoscopy for any other reason, you're weighing all of these things in when making the decision. So it is not just black and white that every fatty liver should get an EUS-guided liver biopsy. but speak with your hepatologist. Usually these patients are sent to me when hepatology's made the decision that yes, Shivangi, we need a biopsy on this patient, and by the way, can you also look at this while you are there, or can you also evaluate the patient for patients been having GERD or something and are going to need an EGD. So they've already set it for me before I even receive the patient, because again, mine is a purely therapeutic practice, so I'm not the first in line who's seeing them.
Great, thank you. And Dr. Schulman?
Yes, I agree 100%. It's always a discussion with our hepatologists, and they serve as the main referral practice for our endoscopies. Not every patient, and oftentimes, the diagnosis can be made with just the change in liver function tests or, non-interventional imaging and other modalities. And so it's really the select patients that are sent to us for the procedure that we meet.
Great. I would like to take a minute to just wrap everything up here right on time. I would like to thank both of our educators for the wealth of information that they provided to all of our attendees this evening. And for all of our attendees, you'll be receiving a survey after this webinar, really just assessing what we were able to provide to you today. So if you could take 2 minutes to fill that out, that would be greatly appreciated. We would like to thank WIE for partnering with us on this wonderful webinar event on endo-hepatology. And we would like to wish everybody a nice weekend and a great rest of your evening. Thank you both so much.
Thank you.
Thank you. Thank you.